I will be talking about post-transplant program assessments and whether long-term outcomes are more important than short-term outcomes. I have no financial relationships to disclose relevant to this presentation. My presentation does not include any discussion of off-label or investigational use. As I'm sure many people are aware, regulatory review and public reporting currently use assessments of 1 year post-transplant graft and patient survival. We sometimes hear arguments that longer-term outcomes are more relevant to patients because they have larger differences in absolute survival. At the same time, we also hear arguments that shorter-term outcomes are more important because programs have more influence on outcomes immediately after transplant, and program-level variability is actually highest immediately after transplant. To help address these two conflicting arguments, we sought to empirically investigate the relative importance of different lengths of post-transplant follow-up. As a secondary question of interest, we also investigated the effect of the width of assessment cohort. This is because we sometimes hear that the current post-transplant evaluations are not relevant because they include follow-up from over 3 years before the release of the PSR cycle. In order to empirically evaluate the relative importance of a given post-transplant outcome assessment, we estimated the association at the time of listing with subsequent post-transplant graft survival. By comparing this association across the different lengths of post-transplant follow-up and widths of assessment windows, we can determine the relative importance of the different dimensions. One of the difficulties in including longer-term follow-up into the post-transplant outcome assessments is the long data lag between transplant and the follow-up period. This has traditionally reduced the utility of these long-term post-transplant outcome assessments. The best example is the current 3-year post-transplant outcome assessment included in the program-specific reports, which includes data from over 3 years ago. For this reason, the post-transplant outcome assessments were estimated in a period prevalent cohort rather than an incident cohort. As we illustrate in subsequent slides, the period prevalent cohort only uses the most recent follow-up, even for longer-term outcomes. The easiest way to illustrate how period prevalent cohorts only integrate the most recent follow-up is through a simple example of 5 recipients that were transplanted on January 1st of 2013, 2014, 2015, 2016, and 2017. For a 2-year incident cohort between January 1st, 2016 and December 31st, 2018, only patients D and E would be in the incident window. Because it's only 2 years wide, we would only have up to 2 years of post-transplant follow-up. In contrast, a period prevalent cohort will include the older transplants, but only focus on follow-up during the evaluation window. For example, if patient A had graft function on January 1st, 2016, then the post-transplant outcome assessment would include the 4th and 5th years of follow-up. If patient B had graft function on January 1st, 2016, then the post-transplant outcome assessment would include the 3rd and 4th years of follow-up. Of course, patients D and E would still be included in the period prevalent cohort. We use the period prevalent cohort to estimate the association of the post-transplant assessments at the time of listing with subsequent post-transplant outcomes. Again, we were specifically interested in 2 dimensions of post-transplant assessments: the length of post-transplant follow-up, 1, 3, and 5 years, as well as the width of the assessment cohort, 6, 12, 18, 24, and 30 months. We investigated the effect of these different dimensions for kidney, liver, lung, and heart patients listed between July 12, 2011 and December 15, 2015, who subsequently underwent transplant before December 31st, 2018. Each model adjusted for additional recipient and donor risk factors. While these dates may look a little weird, they correspond to the start and end dates of different PSR cycles. And in fact, there are 9 different historical PSR cycles included in the time between July 12, 2011 and December 15, 2015. One of the difficulties with this study is that the post-transplant outcome assessments have never previously used period prevalent cohorts, and that these models must be retroactively estimated. This creates a somewhat complicated study design. On this slide, we outline the 4 steps required to estimate the effect of post-transplant outcome assessment at listing on subsequent post-transplant graft survival. The first step, we estimate the risk adjustment models for the post-transplant graft survival in the historical PSRs with a period prevalent cohort. Using these risk adjustment models, in step 2, we estimate the post-transplant outcome assessments in the historical PSRs. When we say post-transplant outcome assessment, what we're really saying is that actually the program-specific hazard ratio. So, using these risk adjustment models and program-specific effects from steps 1 and 2, we identify the appropriate post-transplant outcome assessment for each candidate listed between July 12, 2011 and December 15, 2015, who subsequently underwent transplant before December 31, 2018. As a reminder, these dates were selected as the start and end dates of PSRs, while December 31, 2018 was selected to ensure sufficient post-transplant follow-up for the patients and candidates included in the study. In step 4, using the candidates identified in step 3, we estimate the effect of the post-transplant outcome assessment at listing on subsequent post-transplant graft survival. So, using these steps, we can estimate the association of a single post-transplant outcome assessment at listing on subsequent graft survival. Remember, we have 15 post-transplant outcome assessments to evaluate. And we're really interested in the effect of different dimensions of these post-transplant outcome assessments on subsequent graft survival. So to analyze that, this slide presents a heat map of the kidney results. And so a darker blue essentially corresponds to a stronger association of that given outcome assessment with subsequent graft survival, whereas a lighter blue, or almost a white, corresponds to essentially no association or a weak association of that given post-transplant outcome assessment with subsequent graft survival. And as you can see on this slide, the years of post-transplant follow-up, longer follow-up generally has stronger associations with subsequent graft survival, and actually more narrow PSR evaluation windows have weaker associations with subsequent graft survival than wider PSR evaluation windows. This slide presents the results for liver transplantation, and the gradient is not as strong as it was for kidney, but again, the evaluations with 1 year of post-transplant follow-up generally have weaker associations with subsequent graft survival, and the post-transplant outcome assessments with more narrow, specifically 6-month evaluation windows, have weaker associations with subsequent graft survival. In lung transplantation, we see a similar pattern of association as liver, where the 1 year post-transplant outcome assessments had the weakest associations with subsequent graft survival, and the more narrow post-transplant evaluation windows also had the weakest associations with subsequent graft survival. It's important to point out that these scales of these hazard ratios are actually different across the organs, and that lung actually has the strongest association with subsequent graft survival than the kidney and liver results, as well as the heart results that we show on the next slide. Heart probably has the most unique pattern of associations out of all the organs. For the post-transplant outcome assessments with only 1 year of follow-up, there's essentially no association, or it is extremely weak. However, there are associations for the post-transplant outcome assessments with 3 and 5 years of follow-up. However, there is no real gradient between 3 or 5 years. Additionally, and in contrast to the previous organs, there is essentially very little difference between PSR evaluation, narrow PSR evaluations and wider PSR evaluations. So, taken together, what do these results mean? Essentially, we found that post-transplant outcome assessments based on 1 year of follow-up had uniformly weaker associations with subsequent post-transplant outcome than assessments based on 5 years of follow-up. We also found that wider assessment windows typically had stronger associations than more narrow assessment windows, although the associations were relatively similar for 18, 24, and 30-month assessment windows. It's important to point out that we generally believe that this study is most relevant to patient decision-making because associations at the time of listing provide actionable information to patients. In contrast, identifying program-relevant post-transplant outcome assessments may require a different approach because programs are probably interested in whether or not short or long-term outcomes are responsible for a period of poor post-transplant outcomes. Finally, On this slide, I provide some additional references. The first reference is the paper corresponding to this given presentation, which was recently accepted in the American Journal of Transplantation. The second paper is a similar approach to understanding the association of post-transplant outcome assessments with subsequent outcomes, specifically related to the current SRTR post-transplant 5-tier system. The last two references are additional information on understanding peer-prevalent cohorts and how they can improve estimation within transplantation. Thank you for listening to post-transplant program assessments. Long-term outcomes are more important than short-term outcomes.